So first, Baha Zaidan, CEO at Azalea, has sent his meaningful use expert to be with us. Ashley's been down in the weeds and can give us some good information today. We'd like to thank Baha for his support, and hey, we wish him lots of luck on NPR today. And we also have Cathy. Let me introduce Cathy and Ashley. Ashley first is Azalea's project manager. She joined in 2009, and her primary focus is to communicate meaningful use requirements to Azalea's clients and served as the critical go-to person to ensure successful implementation of its application. She also worked with the development team to ensure that Azalea meets the meaningful use certification standards. Big job. And we also have Cathy, Hometown's managing director. And for those of you who don't know, Hometown is a network of about 55 hospitals and supporting business partners. She directs the management services offered to our hospitals, such as the SHIP Grants Consortium, HIPAA, group purchasing programs, business office performance, Hometown Health University, and more. Cathy saw the need for the business office training as key to survival for these rural hospitals soon after she began working for Hometown in 2000, and since has led, I don't know, over 500, but it has to be many more than that, boot camps, workshops, webinars, conferences, and training. So thank you, Ashley. Thank you, Cathy. Thank you, Mark, for all being here today. And I am going to turn the screen over to Ashley. Where are you? And you can take it away. Thank you, Ashley.
All right.
You should have the screen.
Okay, one moment. Let me make sure my presentation's up. I apologize. I was thinking you were going to control it the whole time and have my presentation up.
Well, I do have it, Ashley, if you need me to.
I think I can get it up real quick. I'm sorry. I didn't know I'd be able to have controls. One moment.
I do have it right here if you need me to.
Let's see. All right. Okay. So just to kind of go over some of the things that I'll cover today, or that we'll cover, we'll go over the fact that the Stage 2 meaningful use has been extended through 2016. We'll go over some of the Stage 2 requirements, what the physicians need to know about Stage 2. We'll dig into the E-prescribing requirements and relate examples of successful incorporation and sharing of lab results. We'll also, cover if you're eligible to start Stage 2 and the difference between Medicare and Medicaid. And the first thing I just wanted to make sure everybody was aware of is that CMS has proposed a new timeline for the implementation of meaningful use, and it has now been extended through the end of 2016. So if you were unable to attest for Stage 2 meaningful use this year in 2014, you will be able to do your 2 years of Stage 2 in 2015 and 2016. And at this point, they haven't proposed Stage 3 to begin until 2017. So that's good news for everybody who hasn't began Stage 2 yet. Under Stage 2, providers must meet 17 core measures, 3 menu measures, and report on 9 clinical quality measures that cover at least 3 different domains. So what that means is that for the 17 core measures, eligible providers are required to attest for all 17 of those core measures. When we're speaking about the menu measures, that means there are a total of 6 menu measures under Stage 2, and eligible professionals can choose 3 of the 6 menu measures. So that's why they're called menu, because you can choose from the 6. And then for the clinical quality measures, they will need to attest for 9, and of those 9, they will need to cross at least 3 different domains. The thing about clinical quality measures is that there is no threshold that the providers have to meet like they do when it comes to the core and menu measures. They just have to report on the data. So when you're testing or you're reporting your clinical quality measure numbers, 0 is an acceptable value. It's strictly just reporting out of the data out of your EHR. And when it comes to what you need to know about Stage 2, just to kind of 30,000-foot view, one of the things is that a lot of those stage 1 objectives, they are carried over to stage 2. So that's a great thing. For example, the recording of the smoking status, under stage 1, it was 50% threshold that you had to meet. And then under stage 2, it's now gone up to 80%. So that's kind of a great thing. If you've already attested for stage 1 and you know a lot of the measures and you've already been meeting them, the only change is that a lot of those measures are now come over to stage 2, but there's just a higher percentage. Another thing is increased patient engagement. So for example, under stage 1, the patient electronic access measure only required that providers had to register 10% of their patients with the patient portal within 4 business days. Now under stage 2, they're taking it to a different level. They're not only do they have to register 50% of their patients with the patient portal within 4 business days, but of those 50%, now more than 5% of those patients actually have to log into their patient portal and view, download, or transmit their health information online. So a lot of what we're recommending practices do, and I know it's tough because a lot of people say, well, it's hard. How can I control my patients actually then logging in after I register them? And, we're just recommending that, not only do you obtain the patient's email address during the patient intake process and try to, educate them about the benefits of, online records, but actually offering to assist them with logging into their email and registering with their patient portal during their office visit if it comes to, really trying to meet this measure. And then another thing is enhanced interoperability and health information exchange. Under stage 2, the summary of care measure objective now requires that an array of structured and coded data be formatted uniformly. So when we got our stage 2 EHR certification, we had to follow a certain structured data coding format for generating the referrals out of our software. And it actually requires that more than 10% of the referrals generated are sent via direct message. So there's a lot more standards amongst the EHRs now under stage 2. And then so what are some of the stage 2 requirements for e-prescribing? At this point, I just wanted to go ahead and turn it over to Cathy, and she'll be able to tell you a little bit more about e-prescribing in depth. And presenter.
Hey, Cathy, are you there?
Yes.
Okay.
I am ready. Hello. Hi, everyone. Thanks for joining today. I think it's time that let me start my PowerPoint. I think it's time that we all take it from reporting measures and checking boxes and, from the technical perspective to really talking a little bit more about what's making this measure meaningful, taking it from a task to something that changes lives and saves lives and really the meaningful makes it meaningful. That's the whole point. If we don't begin to incorporate some of these new attitudes and help bring our physicians and our clinicians with us on the meaningful use journey, we're just not going to continue in a consistent way to be able to meet these measures if it's not meaningful. So I think we need to always remember MU. We make these MU, we write it down on our list, but what does it mean to us? And so I just go along with me for about 10 minutes and let's talk about what makes it meaningful. So very important. E-prescribing in a nutshell is ERX, a fast, efficient way to write or reorder and transmit prescriptions. That's what we see so many times, but digging deeper. E-prescribing is really preset fields in the record where all the required information is entered in. It's automatically stored in the patient's record for easy review during follow-up visits or for transitions to other providers or types of care, whether it's long-term care, home health, that people are able to actually have access to those prescriptions. Of course, it increases overall patient satisfaction because prescriptions can automatically be transmitted to the pharmacy of our preference. And how cool is that from a patient perspective? And using our electronic EHR provides guided dose algorithms to assist providers, much less opportunity for error. And then, of course, all the providers have the opportunity to query a formulary to ensure that the drug they selected is covered by the patient's health plan, and which, of course, reduce cost to the patient, really make sure that it's covered. So this goes way beyond just the task, the technical perspective. We have to really understand what it means to the patient. Check this out. I love this chart. It's more than just a list of objectives and measures. What does it look like in your practice, and whether it's a hospital-based practice or an independent practice? We've got the collected structured data that's listed here for Stage 1 and Stage 2. I'm not going to go through each one of them, but from that, collecting that data, then we go over to how we use the data to support our practice and the care we provide through drug allergy checks, clinical decision support, patient profiling. Those are the things that matter, isn't it? And then we use that data for patient engagement, send them reminders to educate them, to summarize their encounter for discharge instructions, and chart export from one provider to the next. Then we use that data for care coordination, reporting to public health, through a data health information exchange, through medication reconciliation, summaries of care, which are incredible. If you've been released from discharged from a hospital lately and you've had your summary of care updated into your patient portal, now when you get home, you know that your mind is going 90 miles an hour and you don't comprehend everything that the nurse tells you. But when you can get home and you can log in and you can look at those prescriptions, you can look at the plans and instructions, it's meaningful. And all this in a very private and secure environment. That is what makes the difference to the patient, the end user. So the functional objectives are to generate and transmit permissible prescriptions electronically. I wanted to just educate you all just a little bit. Some of us have a lot more experience than others in the field, but I want to make sure that you're aware of the Dea Diversion List. I'm going to escape, and I want to go over to the website. Now, the link is there, but this is an updated list, and this list has been updated effective. I can get there. So here it is. This list of controlled substances that are excluded from the e-prescribing measures. Remember that it's permissible prescriptions that we're counting, okay? So this is updated September 2014. I just want to encourage you to use this link to go pull down this list to make sure that you're not counting any non-permissible EHRs. E-prescribing measures. Okay. Now let me go out of that and get back to my when people say permissible, it's even in the definition. The next slide shows you there's two definitions in e-prescribing: permissible prescriptions and then prescriptions. Yeah, and so just remember that we've got to be educated on that controlled substance list published through the Department of Justice. So what does it mean for us in our practice? What does it mean for our patients? It means that we know what can be electronically prescribed, all medications other than controlled substances we just looked at. That includes new orders as well as renewal requests. Prescriptions for all patients, not just Medicare and Medicaid patients. Very important. And then who should enter the medication order in your office? that can be entered by the physician or any licensed healthcare professional in the state of Georgia or in the state that you're in. When should they be prescribed electronically? All medication orders except for controlled need to be prescribed electronically, including those issued during the visit, telephone encounters, e-visits, portal messages, any way that you communicate and to provide prescription, they should all be entered electronically. And where should the medication orders be entered? Typically, you're using an e-prescribing system or the e-prescribing component of your electronic health record, like Azalea. Of course, you need to verify, always verify, that the system is actually sending the prescription and not a computer-generated fax. That's sort of a workaround, that the computer-generated fax does not count in your measures for e-prescribing. Very, very important. And, use this as the justification and the education for the clinicians. Why e-prescribe? To create a more efficient and safe process for patients to access their medications. Electronic processes help to prevent the top reasons for errors, including illegible handwriting, incorrect dosing, missed drug allergy reactions that are automatic in our e-prescribing or EHR technology. That improves patient safety. It controls costs that occur due to medication errors. So remember, I'm going back to Ashley's initial slide. There are two requirements that relate to e-prescribing. CPOE requires 60% for Stage 2 of medication orders created by the eligible professional during this reporting period using CPOE. Second, now we're moving from 40 to 50% of all permissible prescriptions written by the EP queried and transmitted electronically through the EHR software. Barriers, always, just remember that there are going to be external barriers that are beyond your control. There are going to be pharmacies that are not connected to e-prescribing. The attestation for the e-prescribing objective counts all prescriptions, and with the only exclusion being the controlled substances we talked about earlier. But I want to make sure you have another really awesome resource, and I'm going to close with this, is this on AHRQ, and you might want to write this down and also make sure that you get this incredible toolkit. First is on healthit.gov, gives you everything for meaningful use Stage 2 by category, by measure, and then it connects. This is just the key page. And when you click down here on healthit.gov, providers-professional, achieve meaningful use, and then this link is there. You're going to go down here to this tool set for e-prescribing, and when you go there, it's on AHRQ. It is a step-by-step, and I'm afraid that I might have clicked off of that. It's a step-by-step series of awesome implementation steps for you. We're also giving you the resource to the Stage 2 core measures, and e-prescribing is the measure 2 of 17. So use these resources, and let's demystify e-prescribing a little bit. Let's dig in and let's commit to it, to the long-term, improved outcomes and better patient safety for our patients. So thank you, Sherry, for letting me dig in a little bit and talk a little bit more about how important it is to get our practices engaged and on board. First, Stage 1, with your 40%. So we've got to make a concerted effort right now. Let us know if we can help you with any additional training or information. Now I guess we'll go back to Ashley.
Hey, sure. Ashley, I'm going to give you back the screen, if that's okay. Hey, Okay, while she's taking the screen, there is a question. I'm going to go ahead and ask it, Cathy, and see if, while Ashley's getting hers back on. Let's see, and I don't know these abbreviations very well, so forgive me, but for the counts, does it only apply to new RX, or does it also apply to, is that REF RES, REF RES for the actual calculation?
Is that talking about renewed? Yes. If it's
Since it's not a real script, is what he put.
Remember, in any category, going back to that slide and use those slides, any category where you're prescribing or renewing a prescription, yes, it counts. Only thing that doesn't count is controlled substance. Hey, Sherry, I forgot to launch the poll. I want everybody online today. I just want you to quickly give us a little bit of input. I want to ask you, be honest, about how your office is doing right now on the e-prescribing initiative. So I want to launch it, and Sherry, if you want to do the lab results, you can do the second one after Ashley finishes lab. But y'all give us, we're going to take about 30 to 40 seconds, and tell us how you're doing. Rate your practice or your practices on the e-prescribing, on the actual adoption and using those meaningfully. Tell us how you're doing. All right. Good job. Everybody's doing great. Let's see. I'm going to give you about 10 more seconds. Only 62% of you have voted, so a few more of you make a choice. And I think this encourages us to know where we are and where you are in a rural hospital-based and independent practices. 85%. Good job. Check it out. Let me close it, and I'll share it with you. Share. 64% are great. 36, okay. So that's wonderful, guys. Y'all, congratulations. Keep up the good work. I will hide that poll. And we'll go back to Ashley. Thank y'all for letting me share.
Thank you. Ashley, are you there?
Sorry about that. I was going to thank you, Cathy. And the next thing we were going to cover is the incorporation of lab results. And the Stage 2 requirements for the clinical lab test results measure requires that more than 55% of all clinical lab tests ordered by the EP during the EHR reporting period, whose results are either in a positive or negative or numerical format, be incorporated in the certified EHR technology as structured data. This clinical lab test results measure is a core measure. Therefore, all EPs must meet these requirements in order to achieve Stage 2 meaningful use. Examples that we have, Azalea Health, of successful incorporation and sharing of lab results, we actually have interfaces with Solstice Labs, Quest Diagnostics. We're currently working with LabCorp to get that interface live. And the way that it works is that the lab result comes through the interface from the laboratory and is displayed into our EHR. And then upon accessing we have a CPOE screen where the providers can see all of their results that have come through, and they can view those results and archive them to the patient's record. And it's as simple as those steps of viewing the result and archiving it to the patient record, and at that moment it is now calculated towards the incorporation of lab results, clinical lab results measure. So it's really, important to be able to have those interfaces because it makes it that much easier to incorporate those results and increase your calculations. Another thing I wanted to cover with everybody, just to kind of summarize the meaningful use and Stage 2 requirements, one of the things is, are you eligible to start Stage 2? In order to begin Stage 2, you will need to have participated in at least 2 years of Stage 1 prior before you can proceed. There's been a little bit of confusion in the past with the Stage 2 having to just skip automatically to Stage 2 in 2014, and actually you would need to first attest for 2 years under Stage 1 before you can move on to Stage 2. And then this is just kind of an overview of the difference between the Medicare and Medicaid meaningful use programs. When you first sign on to a test for meaningful use or participate in the meaningful use program, you'll need to register for either the Medicaid or Medicare program. The Medicare program is run by CMS, while the Medicaid program is run by your state's Medicaid agency. The maximum payouts for the Medicare program is $44,000, while the maximum incentive program payouts for Medicaid is $63,750. With Medicare, the payments are over 5 consecutive years, while with Medicaid, the payments are over 6 years, and they actually do not have to be consecutive. So providers actually can skip a year with the Medicaid and then come back and participate the next year and still receive full incentive payments. For Medicare, the payment adjustments will begin in 2015 for those providers who had not began participating in the meaningful use program. While with Medicaid, there are no adjustments. The minute you start participating, you will start receiving the payout, the incentive payouts. Another thing is with Medicare, providers must demonstrate meaningful use every year. And then with Medicaid, the great thing is that providers can actually, their first year of participating with Medicaid, they can just attest that they purchased a certified electronic EHR, and then the next year they would actually participate in the meaningful use for the reporting period. And then how do I register for the meaningful use program? If you have yet to register for meaningful use, you can actually visit the link below, and this is the link where you would actually log in and register for the program, and then once you're registered, after you've done your reporting period in your EHR, you would go back to this same website and log in to attest your numbers online. And then one thing I just wanted to say is that Azalea Health, we are, very excited to announce that this year in 2014 we have obtained our Stage 2 Ehr certification.
Yay!
So we're just very excited. We've worked very hard over the last year, so we just wanted to let everybody know that. And there's actually, out of the 1,200 EHRs that were Stage 1 certified, in 2014, there's currently a little over 100 ambulatory certified EHRs for Stage 2. So it's a huge accomplishment on our end. And are there any questions that anybody has about meaningful use overall? Or?
Yes, this is your time. You can ask Ashley Stage 1 questions, Stage 2. Anything further? I don't see any coming in. Guys, feel free to type it in the question and answer pane or in the chat message, or raise your hand and we'll open your line. We'll give you just a second, and meanwhile I'm going to launch this poll, hopefully, right now. Rate your physician practice on incorporation of lab results. Again, great, okay, and not so good. We'll give you a few seconds to do that, so please go ahead and type in. We're at about 20 seconds. Meanwhile, anyone that has any questions or to type into the question and answer pane. Oh, I see one coming in now. We have 60% voted. Just another couple of seconds, and I'm going to close it. And I'm going to share the results with you. Rate your physician practice on incorporation of lab results. Great, 50%, okay, 38%, and not so good, 13%. Well, you're on today, so you're improving. And thanks for taking part in that. We appreciate it. Now let's get to the questions we have here. Hold on, I got to move things around so I can see. I have a physician that just started in our office on September 2014. Prior to that, he was working in occupational medicine and did not take part in meaningful use. Can he attest for Stage 1 this year? As I have read online, the providers must have registered by a certain time earlier than this year to attest.
Yes, unfortunately for this year, 2014, the cutoff date for the reporting period, the last reporting period, was to start October 1st, and I believe the registration deadline was in September. So 2014 is actually too late for him to begin his reporting period and to attest for 2014. But he could start in 2015. Now, I believe beginning in 2015 does not give you would gain him any incentives for participating, but it would help him to steer clear from any payment adjustments for Medicare if he were to participate in the Medicare. If he were to participate in Medicaid, he could go ahead and begin in 2015, and he would still be applicable for some incentives at that point.
Okay, thank you, Ashley. And I have one more. Can you answer this one? If not, we'll see who else can. Please clarify CPOE through the EMR.
That is computerized provider order entry. So the CPOE would be the actual ordering of the lab. And if you had an interface when you place the laboratory order from within the EHR, it would then automatically send that order over to the laboratory that you have an interface with. And then the incorporation of lab results is the one where it comes back through, the results actually come back through the interface. So there is the CPOE measure. And for stage 2, there's the CPOE measure covers 3 requirements. The CPOE of lab results, lab orders, radiology orders, and medications.
Okay. Thank you, Ashley. I'm sorry, I'm reading on down. I hope that answered their question, and it's being typed in right now. Since e-prescribing is done inside the EHR, wouldn't all e-prescribing count as CPOE for meds?
It would, as long as those prescriptions were signed and sent. That is correct. So if you had an electronic prescribing, if you did your electronic prescribing through your EHR and you signed off and sent those medications onto the pharmacy, then that would count towards the medication CPOE portion of that measure.
He says, thank you. Okay, let's see, do we have any other questions? Any hands raised? Okay, I'm going to appreciate that so much, Ashley. We're going to turn it over to Mark Renfro really quickly to give a couple of updates, and if any more questions come in, we'll ask those at the end. Mark, do you need the screen?
Can you let me share my screen briefly?
Sure. Let me turn it over to you, Mark.
Okay.
Ashley, if you'll just stay with us in case there's any other questions, we'd appreciate it.
Okay.
Thank you.
Start off with, I'd like to welcome and thank you all for joining us today, and just want to let you know that Sherry Eckerman, myself, Mark Renfro, and Jesus Ruiz are here to help you. And one of the things we're very excited about doing is help the physicians. We've been working with the hospitals over the past 3 or 4 years, and right now we're looking at this year's our first year of working with the physicians. We can help you go through understanding the requirements and also understanding how to attest and also how to assist you in getting paid. So those are some of the things that we can do. We recently had one hospital who had attested but had failed to do the payment, and we're working with them right now to get their payment for their first attestation. Back to one of the questions that was asked earlier with a new physician joining your practice. For 2014, I've got the screen up. September 30th was our deadline for the hospitals physicians was October 1st. So you can start enrolling them for 2015, your physicians going forward. And one of the things that we also want to address is they've got to February 28th to get enrolled and start doing their attestation for Medicare. Okay. One of the things I want to bring up and mention quite a bit is Medicaid is really a tremendous opportunity right now. If you notice the difference up there on the screen, Medicare is $44,000. There's stiffer rules in there. Medicaid is $63,750. The only requirements is you must have 30% of your patients must be Medicaid eligible, and you must be, seeing that in that. We will help you go through, work with the state to determine whether or not you qualify. Pediatrics, they can go down to 20%, although they get a reduced amount between 20 and 30, but they can go down to 20%. You've got 6 years on the Medicaid. And the state is very interested in trying to get the physicians to adopt. We've had, a lot of delayed physicians out in the rural areas, and we're really trying to assist them to look at selecting. And your first payment is, again, for you to adopt and implement your EHR technology. Then we're going to go through and demonstrate the remaining 5 years for meaningful use and how you're going to demonstrate utilizing the system, so to receive your incentives. Quickly, I'd like to bring up one other screen on that. And if you notice, you can start receiving your first payment in 2015, which is $21,250, followed by $8,500 the remaining 5 years. And this gives you an opportunity to really get in the program by selecting an EHR. And we've had a lot of the rural hospitals, physician groups out there have not selected one. So we're there to assist, help, and work with you on these programs. So again, I just want to bring that up and point out again that for pediatrics, if you meet 20% of your Medicaid patient volume but fall short of the 30%, which is required for all eligible Medicaid providers, you are just, pediatric would reduce down to 2/3 of that incentive program. So those are some things to think about. We're here to help you, to assist you on that, and work with you. One other thing is right now we're trying to get some verification when we can start testing. Right now with Medicaid, please do not attempt to start your program year yet. They will be sending out a notice to us very shortly. And again, all we have to do for the first year for 2015 is to adopt and implement or upgrade your meaningful use to meet those requirements. And you must have 30% Medicaid patients. And again, if there's any questions about that, we'd like to really discuss that at this point. Sherry, anything else you would like to add, or Jesus, you'd like to add anything at this point?
Okay, I do not. Jesus, if you have anything, just speak up. I have one more question on the Q&A pane. It's a follow-up to the CPOE question. So I believe Ashley, for radiology, does the order have to reach the facility electronically to count for that measure?
It does not. At this point, all you have to do, because they've actually made it for where as long as you enter the radiology order in your software and then record the result, you will meet the radiology CPOE measure by just strictly entering the order. And then you would meet the imaging results measure by just entering the result. They have taken into consideration, that those people who don't have interfaces, they're not going to penalize people for not having an interface. So that as long as it's recorded in the EHR, you can still meet that measure. The interface actually just makes it a lot easier. You have less work because the result would automatically come right into the EHR, and you'd be able to order that radiology order straight from your EHR.
Okay, Deborah, I hope that answers your question. If you have any follow-up, just don't hesitate to get in touch with us, and we'll get your questions answered for you. Thank you, Ashley. Thank you, Cathy. Thank you, Mark. Are there any final comments for anyone before I close us out?
This is Jesus. Just wanted to remind the physicians that if you have not registered, it is important that you register as soon as possible, because it does take time for the registration to come over to the Medicaid side. So that is important, especially considering that if you have not attested yet and you're not attesting in 2015, there no longer is, or in 2014, there no longer is any Medicaid and Medicare money. The only incentive payment that you can receive from this point forward will be Medicaid.
Okay. Thank you, Jesus. Anyone else have any final comments or questions? Wait, here's another question. Does the image, we're going back to CPOE and radiology, does the image itself have to be scanned into the EMR, or will the written results suffice?
When we got certified, I believe the written results sufficed. As long as it's entered as structured data in your EHR, and it can, take those calculations. It depends on the EHR that you're utilizing. I know with ours, you couldn't strictly just scan in the document and it count. It had to be entered into the result had to be documented in our system as structured data. And we have a place in our EHR for documenting the radiology results. And that's what increases the calculations on our dashboard.
Okay, does that help? All right. Are there anyone else or any other comments? Okay, guys, thank you for joining us today. Don't hesitate to get in touch if you have any other questions or need help. We invite you to visit Hometown Health University, that's HTHU. .net, and see the education that Hometown Health University has to offer. Also, I'll be sending out a link to this recording so you can find it on the Georgia High Tech Online Training Center on georgiahightech.org, but I'll send you a direct link to make it easy for you. Thanks a lot. Thank you to our speakers and our presenters. We appreciate you being with us, and thanks to my hometown crew who backed me up today. I wish everyone a happy rest of the afternoon and a great week. See you next time.